Welcome to Cambridge Health Alliance Health is Well. My name is Roberta Robinson. I'm Director of Marketing and Outreach for the Geriatric Division of the Cambridge Health Alliance, including the PACE program. Today, I'm excited to have as our guest Mary Crowe. Welcome, Mary.
Thank you very much.
Mary is from Dimensions, and she's an education specialist. Did I get that right?
That's correct.
I did. I got it right. So tell us what Dimensions does.
I sure will. So Dimensions, we are the largest hospice in the state of Massachusetts. We provide hospice services, we provide palliative care, and we also provide support services.
Okay, so for those that may not know what hospice services are, could you tell us what they are?
Sure. Hospice, a lot of times people think hospice is a place, but actually what hospice is a philosophy of care. And the focus of hospice is actually around care and comfort. It's about adding quality, and it's about comfort and dignity for an individual.
At the end of life.
Absolutely. And when people think of hospice, though, when they hear the word hospice, they often think that it's really for people at the very end of life, like really in the final days. So that hospice word sometimes has a negative connotation. Hospice means hospitality. It's actually a very good word. And it really, when with hospice work, it's about living. So it's not about dying and focusing on that. It's about helping a person to live for whatever time they have left with as much quality and comfort and dignity as possible.
I tell that to people all the time because so many wait till the 11th hour. And I think even some doctors really are not even educated on this as well. And they miss all the benefits that you have to offer.
Absolutely.
What kind of benefits do you offer?
Oh, a variety. It's, certainly with hospice care, you get the benefits of having the team support. And it really is an interdisciplinary team, and it's with the doctors, the nurses, social workers, chaplains, volunteers, hospice aides, bereavement counselors. There's a variety of support that people get. So in addition to those team visits, and it's interdisciplinary because, again, it's about the whole person. It's about the concept of total pain, which Dame Cicely Saunders, who's that founder of the modern hospice movement, spoke of. It's about really tending to somebody's spirit, mind, and body. And if really, as we were talking about this earlier, if somebody does not tend to spirit, mind, and body, we're missing the boat. We're doing a disservice. So you get those team visits. In addition to that, when you're on hospice, on the hospice benefit, you also get any medications pertaining to the terminal illness is covered. Also,
it's a Medicare benefit, isn't it?
It's covered under Medicare, but it's also covered under other insurances as well. So private insurances, also Medicaid, etc.
So Medicare, does it cover, with the hospice benefit, does it cover the traditional 80% with hospice?
So it covers it. Medicare, again, that benefit, so if somebody is under their Medicare benefit, they won't receive a bill from hospice.
It's complete and full with Medicare.
So it's under the
and
Medicare
it's an elected benefit, I think.
Yes, it is. But it's covered under that Medicare A benefit.
Okay, and that's complete.
Yep, so like I said, but other insurance is covered as well, in addition, and also Medicaid. Okay. So, also, it's, depending, hospices are different. Also, if certainly for our hospice, we're the largest hospice in the state, but also a not-for-profit hospice. And if an individual was unable to pay for care, we also do provide free care. So again, that would not necessarily prevent somebody because of lack of insurance. They would not be denied service because of inability to pay. So that's unique, though. Again, that's not like all hospices. All hospices are not the same.
I learned that. They're not all created equal. I have found that to be so.
Yes.
So, Mary, services you provide, are you doing, I'm a Reiki master teacher. Do you do alternative therapy?
Yes, glad you brought it up, actually. Complementary therapies. We actually have a very strong complementary therapies unit, and we actually have skilled complementary therapists on staff. So that's music therapists. We do Reiki and massage. We also have expressive arts therapy, pet therapy, aromatherapy, a number of different things. Now, again, not all hospices have this, and part of the reason is because that's not a reimbursable service. We believe strongly that complementary therapies are critical. There's scientific evidence that prove that it promotes well-being. And this adds to quality.
I get it. I understand.
Yeah. So it helps in a variety of ways in terms of promoting well-being, lessening pain, all of those things. So we think that's an integral part as well.
You know, I have never worked on anyone doing Reiki that hasn't had a sense of love and well-being.
Oh, yes, absolutely.
Really?
Yeah, we
Yeah.
feel very strongly about, again, these are wonderful complements to, again, the other care and services that we're providing. So
Absolutely. And so you do pain management, you do medication management.
Absolutely, yes.
So hospice, I've heard that you cannot, when you elect hospice, then you're not seeking any additional treatment. Is that true?
Well, generally when people get to the point where they're hospice ready, if you will, generally again, they have come to a point where they have decided that care and comfort is the route that they're going. Now, the interesting part about that is, and again, this is not all hospices have this, we do have what's called open access. So there are, and this is a case-by-case basis where people can be receiving, they might be at the end of an experimental treatment or what have you, in terms of those curative types of treatments. But they can do that and then again finish out that and still come on hospice earlier and not wait until they've completed that. The other thing that I want to speak to in terms of that question is, see, sometimes, again, when we think sometimes of what is curative treatment, now people think, oh, if I'm on hospice, I can't receive chemotherapy or radiation therapy, that sort of thing. Sometimes, again, those treatments are not used in a curative way. They're used more in a palliative way in terms of helping to lessen pain and other symptoms. So when that's the case, when it's a more palliative approach, again, that would not prevent somebody from coming on hospice service.
And just to let the folks know, hospice, you receive a 6-month diagnosis, is that correct?
So, great question. So, again, a lot of times when people are thinking hospice, because like I said, one of those myths and misconceptions is that, and you were talking about people coming on so late, that it's really for people at very end of life. So the general criteria for hospice is the person has a terminal illness and generally 6 months or less. Now, again, how do we know?
We
Right?
don't.
Right. And that's
When I worked for an adult day health, we had a 90-year-old gentleman that came to day health every day.
right. Oh, absolutely.
And he actually graduated from hospice for a while,
yes.
and then he,
Absolutely.
was back on, but
Really, how? And again,
because people do better with all of these,
they certainly
all
do.
of these, the complimentaries and all the attention that they're getting.
Absolutely. You know, how we have to follow what's called Medicare conditions of participation. And how it works is, what they're asking is, does the physician, and it's actually two physicians, the medical director of hospice and the primary care physician, would they be surprised, given the person's diagnosis and the usual course of that illness, would they be surprised if the person didn't live beyond a 6-month period of time? Now, people can be on hospice for much longer than 6 months. But again, what happens sometimes, because of the lack of understanding of this, even with the physicians, like you say, they might think, oh no, the person, they don't have less than 6 months, and they get concerned that there's negative repercussions from that. And then the person might die within 2 weeks.
Right.
You see, so prognostication is not always that accurate, right?
No, that's for sure.
And certainly, one's will is certainly stronger than any scientific prognostication too.
I found that out with my mother.
Yeah.
I did find that out. Absolutely. Yeah, the will is incredibly.
Absolutely.
And it can work for us or against us.
Absolutely.
Yeah.
So what happens is, again, if people are meeting those general criteria, they get approved onto hospice. And then there's the recertification period. So the person would come on for 90 days. And then the physician and the team looks, is the person still meeting criteria? If they are, they get approved for another 90 days. So there's 2 90-day periods in the beginning. After that second 90-day period, is the person still meeting criteria? If they are, they get approved for 60 days.
Okay.
So there's 2 90-day periods and then an unlimited number of 60-day periods. Now, like you said, people can graduate, they can come off hospice,
Right.
And
that's a good thing.
Oh, it's a wonderful thing. And but people, sometimes it's that extra care really that's helping somebody.
That's true.
So that's the hard part too, because they might come off hospice and then they decline.
Fail.
So, but again, we monitor somebody, and certainly if they've stabilized or they've improved, that's one of the misconceptions too, Roberta, is that people think, oh, I come on hospice, And, they think that a person's just, again, they take to the bed and wait for a medical event to occur. Not true at all. Actually, again, hospice is about living. We want people to maximize quality of life. So, when people come on, and they've done really extensive studies on this, people on hospice care live longer.
I believe that.
And they really do. And these studies show that. So, and the two main reasons were that pain and symptoms were well managed, which adds quality, and also length, right? And the other piece was that it was the extra TLC, so
Absolutely.
that extra support. So it really maximized, again, quality, and it added some quantity on as well.
So I have a friend recently that just passed, and he elected to go home with hospice. Unfortunately, he lasted about 3 days. So he missed the entire benefit of hospice. All of these wonderful things that you're talking about.
And I'll tell you, I wanted to speak to that too, because you brought that up a few minutes ago as well. See, this is why this misconception happens as well, right? This is one of the components, is that people say, well, see, no, I just came on hospice, and 3 days later, because again, some people have this misconception about, oh, I go on hospice and that hastens death. Not true at all, because like I said, the studies show quite the opposite. But what's interesting is that somebody will come on hospice like that, and 3 days later they've died. What happens is that people, they delay it so long.
Right.
And again, because it's that old adage that it's always too soon before it's too late, right? And what happens is that people delay it, whether it's our own denial, or we can't see it, we don't want to talk about it. We never want to see it that our loved one is at that stage. We don't. About the other pieces are, it's hard sometimes to feel like we're giving up on a person, although it's not giving up.
It is not.
It's not at all, right? It's so. For
I
all
think
those reasons,
in this society, though, typically, we're a fear-based society. We're afraid of everything, first of all. So I think the word hospice frightens us. I think death frightens us. And, personally, I call it transitioning. We transition from this life to another. But I think we don't embrace it. In this culture, we don't embrace it as a cycle of life. Right? In other cultures, they embrace it, but we try to hold it off because it scares us.
Absolutely.
And so I think that's part of it. I think that's part of it.
We are a death-denying society, but the hard part with that is that we can deny it, but people are going to die. Nobody's ever gotten out of this world alive, right? So, not that I'm aware of yet. So, the thing with that is that we can deny this, but what happens is, and this is the hard part for me, because I've been a medical social worker for 33 years, okay? And my passion is around hospice care. And what's hard for me is to see, because we deny this, that we deny somebody the opportunity to have this good piece of life. Because you're right, dying is a part of living. It really is. So what we do is we isolate, because we call them the dying. We kind of put people in a separate category, and how isolating and alienating is that? So really, if we can look at this differently and embrace this as a stage of life, we can help people to live fully for whatever time they have left.
And the pain won't be so great for us either.
Right. Well, I think the hard part is it's never easy to lose someone.
No.
It's never
letting
easy.
go is the toughest thing we do on this earth plane.
Absolutely it is. But
it doesn't matter what we're letting go of either.
That's right. Oh,
That's
absolutely.
true.
Loss comes in many forms. But I think if we recognize and we know, our goal should be, this is the way it's going to have to be. So we want this to be a good transition for people.
Right.
You were talking about we don't use the word death and dying. We don't, and like I said, we don't use the word even hospice. People will say, oh, that H word. Listen, hospice means hospitality. There's nothing bad about the word. It's our connotation to it.
That's right.
Right? So we do the same with death and dying, and we use all these euphemisms, don't we?
Right.
I mean, we hardly ever say it. They passed, right? They expired.
Right.
Rotted food expires, human beings don't, right? But you even have other people, the pushing up daisies or the kick in the bucket. And you know what? We don't say it to be funny. We say it because we're uncomfortable.
That's right.
And it's that discomfort, and you can see, and when we present it in that way, how can we feel comfortable and let people do what's natural and what they need to do if we tiptoe around
in the best
this.
way possible.
Yeah.
In the best way possible.
Absolutely.
So now we've talked a lot about hospice, and we've mentioned palliative care.
Yes.
So is there a difference?
There is, and like I said, hospice care is palliative care.
Okay.
But palliative care is not necessarily hospice care. So we talked about hospice, and that's a benefit.
Yeah.
That's a benefit that somebody signs on to. So there's eligibility requirements, right? We're
Right.
talking about that 6
6
months
months.
or less,
Mhm.
the terminal status, all of that. We also talked about that team approach, all of those things. With palliative care, I'll talk about it from our perspective at Care Dimensions.
Okay.
So at Care Dimensions, we have a separate palliative care unit, not unit but a department,
Okay.
and it's a service really. So it's not a benefit you sign on to; it's a service. So basically, our palliative care program is physician and nurse practitioner driven.
Okay.
So basically, again, you don't have
I
to
think
be.
this is where the Cambridge Health Alliance come in when we partner with you.
Well, we
is it?
come in for both areas.
Oh.
So again, we work very strongly with Cambridge Health Alliance. We're very strong partners, and we provide hospice and palliative care, both in the hospital settings,
Mhm.
Cambridge Health Alliance in Everett and Cambridge, and also through the outpatient clinics, the home-based hospice and palliative care. Again, we work through the the primary care practices.
Yes.
So again, we work very closely with this. So it's not just palliative. Again, it's hospice services as well. We
Okay.
do both.
All right.
So, but that distinction is, as opposed to again signing on to the benefit and having that 6 month or less, that sort of thing. Palliative care, like I said, physician, nurse practitioner driven. Person does not have to be terminal in nature. They
Oh.
can have an advanced illness. It's a consultative service.
Oh.
So a lot of times people will say, oh, it's a pain program. No, it's not a pain program. Basically, palliative care can help with a number of things. One is certainly pain and symptoms, right?
Mhm.
It can help in terms of pain and symptom management. So palliative care does a wonderful job at that. If you have a cardiac issue, you're going to go to a cardiologist, right?
Mm-hmm.
If you have an advanced illness, you want to see a palliative care specialist. They really focus on this area. See, a lot of times what we focus on is, in terms of if somebody has an advanced illness, it's like the doctor might say, okay, you have to do this, 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 and this. Well, where in that was, let me understand what your impression is of this. Tell me what your priorities are. I want you to understand the treatment options, the benefits, the burdens, and then I want to understand what your priorities are so that we can align the treatment goals to your priorities.
Oh, you include the person.
Oh, yes, we do. And that's exactly it, because in addition to, again, that pain and symptom management, a big thing that palliative care does is has those advanced care planning or those goals of care conversations. Those are as critical as anything else.
They are. In that aspect, would you then do like the advanced directive piece?
Absolutely, we talk about these things all the time.
So advanced directives, if you want to just explain
Sure.
what they are.
Yes, absolutely. An advanced directive is let me tell you the categories: healthcare proxy, durable power of attorney, and living wills. Those are the three broad categories. An advanced directive is a directive that you put in place when you're able to make a decision of who you would want making healthcare decisions for you when the day comes that you're no longer able to do it for yourself.
If the day comes.
That's right. And I say when, because usually it gets there, hopefully later than sooner for some people.
Yeah.
But again, an advanced directive is such an important thing. It is a legal document. Healthcare proxy, durable powers, those are legal documents. Now, that's important. Now, who should have an advanced directive? Anybody 18 and over.
Right.
I'll tell you, still, even though if I ask people who thinks this is important, I'd have everybody's hand raised of who thinks it's important to have one of these. Still only about 25% of the population has one completed.
That's true. And I can talk to, because I do geriatrics, I can talk to an average, an audience of average age of 85, and they haven't tended to these things because of what we were talking about before, the fright and the acknowledgement, the acceptance that one day, we will not be on this earth. Right? But I'm all in place. I have everything done. And it was my children that had trouble signing things. I didn't have any trouble doing it, but they had trouble signing. And I said, I'm not going anywhere, but we need to do this.
Absolutely.
Because in the blink of an eye, life can change on us.
Well, and people are under this impression that, oh, my spouse can take over, or my children or whatever, and that is not the case at all. Those days are really long past us, when it just kind of moved on to that next of kin. And really, legal, in terms of if you're 18 and over, and if something happens, if you don't have a healthcare proxy, nobody has legal authority to make those decisions over you.
Wow.
So then it can go to a guardianship, which are costly and time consuming.
Very time consuming.
The other piece about this,
And it's a total stranger dealing.
it might not be the person that you'd want to have that done.
Exactly.
So the thing with that is, again, these are important conversations. Some people hesitate to have this or put them in place. They feel like they're losing control
I know.
by signing these documents. Really what you're doing is you're taking control.
Right.
You can have this in place, and it can be behind you, and you can then enjoy life. A healthcare proxy does not go into effect until you've been determined to lack capacity.
There you
And
are.
that's determined by a physician or healthcare worker in that way. So it has to be,
It's like a backup.
Yeah, and again, so it doesn't go into effect when you sign it. So people think they're losing that control. The other thing is, of course, we have this magical thinking, right? That, oh my gosh, if I sign something, something bad's gonna happen.
Oh.
And that's not the case at all.
Again, we're back to the
Yeah.
fear-based society.
Yeah.
So what else can we talk about? We've talked about, the advanced directives as far as full code, partial code, things of that nature
Okay,
as
so
well.
great. So let's talk about that, because really, when I said advanced directive, right? Healthcare proxy, durable power, living will. So let me just say this too. So healthcare proxy, again, who's the person you want?
Right.
When you're talking about that person, make sure you choose them with your head and not your heart. Okay, because again, a lot of times what will happen is we make this decision and we don't want to hurt feelings. Hurt feelings. You want to make sure, and I say that in a joking way, but pick the person. Listen, if you might have the closest person to you, they can't do it.
Yeah.
They can't do it. The other piece to this is, don't just fill out an advance directive. You have to have a conversation. If you don't have a conversation about what your wishes are, only 50% of the time they're followed through on. Not good enough. So again, it's so important that when you're having this, that you really have this conversation. Now, I recently was talking to somebody, and the person wanted this person to be their healthcare proxy, and the person said, I can't follow through on those wishes. And you know what? I appreciate their honesty. If you can't do it, that's not the person for the job.
Right.
You got to make sure it's somebody. It's so hard to make life and death decisions for people, isn't it?
It is. I had to make one for my mother.
Yeah.
It is.
But here's the thing, if you have your healthcare proxy in place and you have that conversation, you're not making life or death decisions. You're following through on someone's wishes. And it's still hard, but it's different.
Right.
So then you have that durable power, which covers the financial component.
Exactly.
And that's something, healthcare proxy can be done. They're legal documents. You don't need a lawyer involved with that. Durable power of attorney, you should have a lawyer involved.
An elder law attorney.
And very specific, because
Right.
again, this is a specialty, and you want to make sure again that the person knows, because there's a lot of changes that happen with this. Elder law,
There are.
absolutely, or estate planning attorney, so they really know what they're doing. Living wills, not legal documents in the state of Massachusetts, but they're critically important, because what it does is it helps people. It's the guidelines to follow. So it's still important to have those down in writing. 5 wishes. Have you heard of 5 wishes?
I've done them.
Okay, so that's a form of
My
living
5
will.
wishes are done.
Yeah, form of a living will.
Right.
Recognized document in the state of Massachusetts. Reason why it's recognized: Wish 1 is a healthcare proxy. Wish 2 through 5 are the living will portion. So although that's not the legal component to that, and
Right.
legally, but it's a guideline.
It's a guy. So we should mention that you can go, if you have access to a computer or children that have access to a computer, you can download a sample of the 5 wishes, and then you can order it. It's a little booklet that has all kinds of questions, and you just put in the answers.
Right.
The
Very
questions are there.
specific.
You don't have to think of anything.
Absolutely. And you do have to use the originals. So you have Aging
Right.
with Dignity is actually the website that you go on to. You can download. It's $1. We actually get them, in a large quantity. So we provide them out to people. Another option too is honoring choices. That's another wonderful tool.
I've not heard
an
of that one.
organization. So they do. It's also so people can have a variety in terms of, again, those tools that they use. So it's important. Now I want to go back to your point, because you were talking about do not resuscitates, and things like
And
that.
we just want to be mindful that we have a few minutes, so I
Okay.
want to make sure we get all this information.
So I just wanted to show you the distinction. We just got, and why I was talking about those again was, those are advanced directives, legal documents. Do not resuscitate MOLST forms. Have you heard of MOLST?
Yes,
Okay,
MOLST.
medical order or Massachusetts order for life-sustaining treatment. Those are medical order forms. They're not advanced directives because those are legal document. MOLST and do not resuscitate, those are medical orders.
Okay.
So a MOLST form is an actionable medical order. Fabulous form, wonderful to do. Again, you're specifically being able to say what I love about the MOLST is you talk about what you want or what you don't want around those healthcare decisions.
Right.
Like
And it's very specific, isn't it?
about do not resuscitate,
Right.
about again like intubation, about artificial hydration, all kinds of things like
Yeah.
that.
And I think that has to be visible. When, like, for instance, if a crisis happened and the EMTs came in,
Yes.
then they're obligated to do everything in their
Absolutely.
power unless they see something that indicates
Put
differently.
it up in the refrigerator. Yeah,
Yeah.
your vial of life.
That's
You
it.
want to have it readily accessible because you're right, they're not going to come in and go through files. So the thing with that is, again, you want to make sure that, but now with the MOLST form though, again, the way that's intended is, you don't just fill it out and bring it in to your doctor. The doctor, physician, or the physician assistant, or the nurse practitioner sits with you and goes over that form and you discuss your wishes.
Oh, good.
That's the way that's intended, and both sides are separate. So you're sitting there and then you're signing off on that.
Oh, good.
If that person is not capable, then their healthcare proxy would discuss that with with the physician, nurse practitioner, physician assistant.
So you see why it's important to do it when you're able to do it, right?
Absolutely. So your wishes are truly followed.
Exactly. And why shouldn't we have what we want
Take
at all
control.
phases of
Absolutely.
life and even at the final stages, right? We have a few more, just a minute, I think.
Okay.
Is there anything that we need to mention that we haven't?
Well, we've covered a lot of ground, haven't we, in a
We
half
have,
hour?
we
So,
have.
I just want to say, again, for people, I know that sometimes people approach this in terms of being fearful of hospice care. Again, hospice care is something to be embraced. And like I said, I want people not to look at it as, oh my gosh, I'm going on hospice, so now I'm waiting for that medical event, or death is going to come sooner. No, it's actually, again, living fully. It's really adds quality of life, and it's a lot of support to that person and also the family system. So I'll tell you, what we often hear is that we wish we had done it sooner.
I know. And even is there some support after the family?
Bereavement
after
follow-up, absolutely. And one of those things is that, but we have bereavement follow-up. We have the only freestanding Center for Grief and Healing in the state, the Bertillon Center for Grief and Healing. And a large portion of the people that we provide support to weren't even on a hospice service. So, but we follow bereavement or that support for at least 13 months after the person's died to those around them, the support system.
Well, Mary, thank you so much for coming on
welcome.
board. I
Thanks
think
for
this
having
is an incredibly important topic, and we don't pay attention to it enough. We don't discuss it enough. But thank you so much.
Thanks
And
for
I think
having
we've
me.
learned a lot of information here.
I
Thanks
appreciate
so
you
much.
having me on. Thank you.